Good afternoon, everyone, and welcome to the Baldrige Foundation's Institute for Performance Excellence webinar, Intersectionality Between Quality and Health Equity. We believe you will enjoy today's webinar that will take a contemporary look at health equity, which has significant relevance and linkage throughout the Baldrige healthcare framework. Before we get started today, I want to take a moment and recognize all of our great sponsors and special thanks to the members of the Mac Baldrige Society, who serve as trustees of the Foundation's Institute for Performance Excellence. And here is today's agenda. Today's guest is Joy Lewis, Senior Vice President, Health Equity Strategies, and Executive Director of AHA's Institute for Diversity and Health Equity. Following her presentation, we will address questions from the audience and have a few closing remarks. So now I'm going to turn it over to you, Joy.
Thank you so much for that introduction, Al. Happy to be here with you this afternoon. And hopefully we've got a good group of folks willing to engage with us and keep this interactive. I'm just quickly going to share a little bit about where the AHA sits on this issue of this topic of health equity. And I'm not going to spend too much time on this slide, because I just wanted to share that as we continue to double down on our commitment at the American Hospital Association, we last year updated our mission and vision statements, which I'm told had not been touched in over 2 decades, to reflect the importance of pursuing health equity in all that we do, whether it's on the policy side, on our advocacy efforts, all of our various initiatives, our affiliate organizations, really ensuring that equity is embedded and interwoven throughout all of our plans. And so when I read this vision statement out loud, it is, for me, in fact, the very definition of health equity. So the AHA vision is of a just society, of healthy communities, where all individuals reach their highest potential for health. And I'll share with you that we actually added just 2 words that essentially transformed the vision statement to be much more powerful. And the 2 words were just and the word all. So just a little inside baseball for you on that. Let's level set around some language to frame this next portion of our conversation, because I know when we talk about diversity, equity, and inclusion, some folks lump them all together. At the AHA, we think about them as 3 core dimensions, but distinct, right? So they're separate aspects of the framework. They're interconnected, but they're defined differently. And so diversity for us refers to the myriad ways, the varied and sundry ways in which people differ. And that could be along race or ethnicity lines. It could be around religion, language, age, one's sexual orientation and gender identity, or how they express their gender, all the way through to ability and disability. And so it's really looking at those differences and celebrating those differences and leveraging those differences to lead to better decision making. Inclusiveness really speaks to how do you take that richness of the diversity that exists in your environment, and how do you create fair, healthy, and high-performing organizations. So that's really putting diversity into action. When we talk about health equity, it's not uncommon for equity and equality to be used interchangeably. And we know that the differences are subtle, but they're clear, right? So whereas equality is treating everyone exactly the same, regardless of what their characteristics and their needs might be, when we're talking about equity, we're focused on providing individuals with the resources, or communities with the resources and the supports that they need to then pursue their health goals, right? So in other words, when you look at this drawing, it illustrates quite clearly where the difference lies by looking at those steps, the ladders, the blocks that the characters are standing on. And what I like most about this slide, I mean, I'm sure you've seen past iterations of this image, but this one has been updated to include social justice on the far right. Because ultimately where we want to get to is a place where the playing field is equal to begin with, right? So that the fence in that image is non-existent and everyone's standing on their own 2 feet, right? And so I think when we talk about the AHA's approach to advancing equity, it's both clinical in terms of improving health outcomes for patients and communities, as well as operational. And on the business side, how do you think about integrating and achieving organizational effectiveness related to diversity and inclusion? And then we know that the disparities that exist are in fact measurable. These are measurable differences when you're looking across different groups of individuals. So in the next few slides, I want to detail for you how health equity is showing up in national headlines and talk about the corresponding response that we're seeing from our federal and regulatory agencies. So the headlines here are pretty compelling, right? They are riveting and compelling. Last year, we saw several researchers and others call for evolving the quadruple aim. And you'll see in the bottom center, the quintuple aim for healthcare improvement, a new imperative to advance health equity. If you remember, the Institute for Healthcare Improvement, IHI, and under Don Berwick's leadership, had put out the triple aim, right? Better care, lower cost, better patient experience. And later added a goal around physician burnout and improving the work life of healthcare providers. And now we're seeing where there's a call to consider equity as an expansion of the triple aim to now have it be the quintuple aim. And then in the far left corner, I want to draw your attention to this Kaiser Permanente report that highlights the modifiable nature of health disparities, where it says research shows that Kaiser Permanente cancer screening eliminated, not reduced, but eliminated disparities. And this was looking at Hispanic populations versus non-Hispanic populations versus their white counterparts. And so I think it's these kinds of stories that really call out the imperative that exists for us to take actions, because in essence, we can reduce a lot of suffering and illness if we are to move further upstream in our interventions. And I don't even think this slide speaks to what we're observing around in the maternal health space. That is just absolutely a vexing problem. It's so troublesome, and it seems to be such a hard nut to crack for a country like the United States, which among all the other industrialized countries ranks at the very bottom of the heap when it comes to maternal health outcomes. And then we know when we think about maternal health outcomes, the first thing that bubbles up in our minds are the disparities that exist for Black women who are dying at 3x the rate of their white counterparts. And we know that things like being fully insured or being highly educated and having a higher level socioeconomic status, all of those are not protective factors against a poor outcome. And so again, just a lot of work that needs to be done in this space. The reality, however, is that these disparities in care have long existed and are well documented. So in 2001, the IRM published Crossing the Quality Chasm, a new healthcare system for the 21st century, right? And in that report, the experts who were on that IOM panel identified and recommended improvements across 6 dimensions of healthcare. And later on, we're going to circle back to what those 6 dimensions were and how we've simply not made adequate progress in some of those areas. The Dartmouth Atlas in the bottom left, for more than 20 years, has documented the glaring variations that we know exist in how medical resources are actually distributed across this country and how they're utilized. And we know that that has implications for disparate outcomes. In 2002, so 2 decades ago, we had unequal treatment, which focused on racial and ethnic disparities in healthcare. Again, another IRM committee panel of experts, they documented the evidence around how people of color were experiencing the healthcare environment. And they looked at the disparities in treatment protocols and offered some recommendations on how to intervene. And since 2003, the National Healthcare Quality and Disparities Report at the very top of this slide, they've gone through the rigor of summarizing the status of health and healthcare delivery in the United States. And the 2021 report in particular was organized into sections that provided an overview of the healthcare system and summarized what it looks like in terms of access, in terms of quality, and also looked at several disparity measures. So I point out all of this to say that it's not for a lack of awareness. This is not a raising awareness exercise that we're engaged in any longer. The fact that we're still having these conversations today signals for me and many others who are working in this space that the pace of change is just simply inadequate. And so we really do need to ramp up our actions and move from performative, measures to really taking meaningful steps and meaningful actions to address these issues. So I think I would posit that most of you on this webinar would agree that there is a moral imperative to take action around what we're dealing with as a society. And again, healthcare being one sector. These disparities exist across housing. If you look at education, there are other systems that are equally plagued with these issues because they are structural in nature, they're systemic in nature. But I think less of you might be convinced about the business case for equity, right? Like, why does it make sense from a financial perspective for hospitals and health systems and healthcare providing organizations to pay attention to equity? So what you have in front of you, this slide, looks at the fact that health disparities actually carry both human and economic costs. And there have been several studies done. I just want to highlight this one that looks at health disparities via the racial equity from a racial and ethnic lens. And from a macro view, you can see these national numbers. And these data are actually a tad old. They're from 2018. So you see $93 billion is being spent in excess healthcare expenditures because we're not paying attention to racial health inequities. 42 billion in untapped productivity and 175 billion with a B, all of these are with a B, in premature deaths. And so with this as kind of what's front and center for us, I think we would be hard pressed to say that there isn't a need for hospitals and health systems. We actually can't afford to not address the inequities we're seeing in our healthcare system, because more and more healthcare is occupying a larger percentage of our GDP. And so I would argue that reputationally, organizations that take steps to acknowledge and address disparities, they actually have the potential to increase their market share, right? Through better brand recognition, through trust, which we know is really important in this work. And so if you're paying closer attention to closing care gaps, then you're likely going to improve patient outcomes. And if you're improving patient outcomes, then patients are going to be engaging with the healthcare provider in a much more positive way. And that should also positively influence one's HCAP scores, right? Consumer satisfaction, patient satisfaction scores. And so I just think there's real inertia. There should be more inertia and more energy put into paying attention to the business side of why investing in equity may have a longer term ROI, but why it absolutely makes sense from a cost avoidance perspective. But what we're seeing is movement at the federal policy level, and in some states also, actions that are aimed at ensuring accountability for equitable practices across the healthcare ecosystem. So that's payers, providers, device manufacturers, pharma. On the national front, we've seen the Joint Commission integrate health equity standards into their processes. This took effect January 1 of this year. And you can see some of the requirements are that there's a designated officer to lead a strategy for reducing health disparities. There will be focused attention given to screening of patients for these non-medical needs, these societal factors that we know influence health. There's also the need to break down the demographics from a quality and patient safety data set, right? So when you look at your quality and patient safety data, how are you slicing and dicing that across race, across ethnicity, across gender, across age? What does that look like? And what are the findings? And then how do you act on those findings? And so there is a requirement from the Joint Commission that folks would be developing an action plan to eliminate the disparities that those data reveal. And then there's the tracking mechanisms that are necessary to update staff. And I would actually expand that to say we ought to be bringing in the community into those discussions as well, right? So let's move on to what CMS is doing. So on day one, when President Biden took up office, he issued an executive order, an EO, for a whole government approach to advancing equity. So that meant that each agency, again, be it transportation, housing, energy, education, had to figure out what's its role, how is it going to tackle the inequities that exists in its particular, in its purview. And so given this administration's significant commitment to equity, which frankly we haven't seen in quite some time, CMS is uniquely positioned, I would argue, to incentivize what's working. What do we know that's already working? Because we're, again, not starting from scratch in this work. And so in its final inpatient prospective payment system rule last August, you saw where CMS started to link health equity to quality through its quality reporting programs. And these three main buckets, right? The new IQR measures, this notion around a birthing friendly hospital, really targeting the inequities we're seeing in maternal health. And then last but certainly not least, a request for more information. Again, CMS really wanting to learn from the field what's working. So we think that all of that will essentially drive healthcare organizations to do much more. We at the HA like to talk about, we bring the carrots and the regulator and the Joint Commission, they're the stick. And so if we're working in tandem with one another, the goal is to, again, move the field to take actions to advance equity. And we know that inequitable healthcare results in lower health outcomes for patients who span diverse groups. So again, whether it's from a racial or ethnic lens, an ability or disability lens, a sexual orientation or gender identity lens, these subpopulations fare worse, their outcomes are worse than compared to their white counterparts. And so when we talk about intersectionality of many of the diverse characteristics that patients possess, we're talking about the overlapping systems of oppression and discrimination that one faces. And I'll use myself and as a prime example, as someone who is Black, who is female, who is an immigrant, and who's heterosexual. So my experiences in the world and with healthcare institutions my experiences are going to be funneled through all of those diverse characteristics that I possess, right? So I am being assessed across those dimensions of diversity. And it has an impact on how I navigate through my day, how I navigate when I approach my care team. And ultimately, the quality of care that I receive is based on my diverse set of characteristics. And so when we see these disparate outcomes, it warrants that we pause and we try to unpack them and understand why are they showing up and what can we do to eliminate those disparities? Because what we do know is that health disparities are preventable. They are modifiable in terms of the burden of disease, in terms of the injury, in terms of the opportunities to achieve optimal health that some folks have the privilege to pursue, while those of us from historically marginalized populations are behind the 8 ball on being able to really achieve our health goals. So I mentioned earlier, we touched briefly on the 2001 IOM report, Crossing the Quality Chasm, a new health system for the 21st century. And again, the experts who contributed to this report, they defined quality in healthcare as the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes, and how are those consistent with current professional knowledge, right? So what does the evidence tell us? And then how are these different individuals and patient populations able to increase their own approaches and their own desire for a certain health outcome? And there were 6 core dimensions, and I don't have to tell you this, the 6 core domains of quality healthcare. It should be safe, right? We should be reducing harm when people show up to access our care. It should be effective, again, based on the science. It should be patient-centered, looking at patient preferences and their needs and what values do individual patients bring to their clinical decision-making process. It should be timely. How do we reduce wait times? And again, potential harms. Care should be efficient, right? We should be eliminating waste from our systems. And last, but certainly not least, care should be equitable. So we should be providing care that doesn't vary in quality based on a certain set of demographic variables. And I would suggest to you today that we've made significant progress in these other areas, and we continue to lag around providing equitable care. And I just don't think it's been given enough focused attention throughout the years. And so if we can agree that it's hard to say you're delivering high quality care if it's not equitable, then I think we'll at least begin to bring others into the conversation and begin to think through what are the actions that we need to take. How do we now actually apply an equity lens to our quality improvement efforts? How do we integrate equity into our quality work? And so every healthcare process change can either improve, maintain, or exacerbate health disparities. And I'll say that again, right? We have an opportunity to either improve, maintain, or exacerbate existing health disparities. And so the multidisciplinary nature of our work and our quality improvement work in particular, our quality improvement teams, I think is a really good place to start to design some effective solutions that straddle both the quality and our equity spaces. We know that disparities remain a common indicator for poor health system performance, right? And during COVID-19, we witnessed firsthand the significant growth, if you will, in disparate outcomes, whether it was more deaths or more hospitalizations for individuals of color, from communities of color, and from underserved populations. that is an indicator that our healthcare system is not doing what it needs to do. So we know that improvements, this third bullet on the left, improvements in equity and quality outcomes cannot be achieved without the collection of standardized data. So how are we going to actually use race, ethnicity, and language data, sexual orientation and gender identity data, again, the societal factors, which many of you refer to as the social determinants of health. At the AHA, we do not use the term determinants because, again, as we discussed earlier, we know that these are drivers of health, or these are factors that influence one's health, but they are in fact modifiable. So when you talk about them being determinants, they sound as if they're hardwired and sets the stage that there isn't much that we can do about this. These might be innate features, when in fact we know that they are not. So let's talk a little bit more about data collection and why that is an actionable strategy and it's frankly the logical place to start when you're thinking about this work of advancing quality and equity. And so I think it is important that our systems of care really begin to understand deeply the experience of people coming into our organizations and accessing care, and then using that experience data to create implementation plans and action plans and interventions to address whatever those findings are. And so unpacking the patient data, I think, is really an important place to begin to figure out where your resources should be deployed, right? How are you going to address the gaps in access, the gaps in quality outcomes? Where do you spend your time, your energy, and your resources? And I think having good data really provides the kind of insights that we know our leadership teams, they eat up data. They live, they exist for data. And so if you can have your data tell the story, it gives our leadership, our executive leadership teams, information to really wrestle with, right? And information to guide strategic plans and implementation plans in support of broader organizational priorities. So I think the first step in any equity transformation journey is really to identify and define the types of data to collect. And at the end of the day, use those data to drive improvements. Another really action-oriented strategy that we think has merit and really can jumpstart conversations on the care side is, how do you render care with cultural humility? Because we know that, again, that has the potential to improve health outcomes, improve the quality of care, and contribute to the elimination of racial and ethnic health disparities. And so in the past, you've heard people talk about, well, cultural competence. We actually are not convinced that competence is the goal, because I think it's really hard for any of us to achieve full competence in someone else's cultural experience. And so it's more around this notion of, how do you provide relevant training? How do you provide the opportunities for cross collaboration across providers and folks in the workforce from different backgrounds? How do you celebrate that diversity so that it shows up in that provider-patient encounter in a way that acknowledges someone's, when you think about a person in their broader context that they come, we're not just patients, because no one raises their hand and say, I want to be a patient today. We find ourselves as patients, but we come from broader context. And so how do you try to understand whether it's the cultural nuances or the language barriers that might exist, or how do you address literacy, again, across different cultural groups? And so there has to be some concerted effort done around recruiting and retaining a diverse and culturally appropriate workforce that reflect the patient demographics that our members are serving. I recognize that that's a longer term strategy. We will never reach full concordance between the folks we're serving and the workforce, but there are some innovative practices that are out there that folks can beg, borrow, and steal from in order to drive at this notion of providing care that is culturally humble and where we're much more aware of the nuances and the differences that individuals bring when they show up on our doorsteps for care. So you may ask, what is the American Hospital Association doing to mobilize our members to take actions that we believe will advance equity? And so I want to share with you a little bit about our health equity roadmap that we launched a year ago in March through the association's Institute for Diversity and Health Equity, which I lead. This roadmap is really an innovative framework that is designed to support hospitals and health systems in their efforts, wherever they are on their journey, to become more equitable organizations, to dismantle the structural barriers, some of which are being done inadvertently, right? Knowingly and unknowingly. We have unintended consequences of many of our policies. And since our policies guide our practices, we really think that that is, at the end of the day, where we need to spend a lot of our time, is building up just policies that will lead to overall improved health and well-being for the populations that we serve. And so the 6 levers of transformation that you see here we believe will help our member organizations understand their capabilities. What is their internal capacity to improve their performance in this space? How do you build the strategy for this work? How do you figure out what the leadership looks like in this space? What are the tactics and the actions that one might take to advance on their journey from knowing to doing? You know, we talk about the knowing doing gap. And so the first step in our health equity roadmap journey is the completion of an assessment. And so once an organization has done the health equity transformation assessment, they will be given their results in the form of a profile. And it's not at the aggregate level, but it's in each of these 6 buckets. Where are you on that equity continuum? Are you exploring, or are you immersing? Or maybe transforming, which is by far the most advanced stage, right? And so this slide shows you that, and I will tell you that of our members, we're over 1,100 members now who've requested the assessment. And of those who've actually completed it, we're seeing that the vast majority of our members are in the exploring stage, which is not shocking, right? Because if folks were already transformed and we still have the disparities that exist in our healthcare system, then that would actually beg the question, and what are we doing? Because obviously something is really awry if we are already in the transforming stage and we still have the kinds of outcomes that we're seeing. So this really just does reflect the ongoing kind of self-sustained progress that is necessary to then end up in a place where folks are much more advanced and are able to then impact the broader ecosystem within which a hospital operates. And I want to be clear about what this is and what it isn't. It isn't a ranking or a rating system. It is really around a self-assessment. So hospitals and health systems are able to move at their own pace. It is taking the assessment is essentially a diagnostic tool to gauge where one is and to decide, well, where with the resources that we need to apply to get from exploring to committing, to go from committing to immersing, and on and on. But the key here really is that taking action, if we're going to eliminate health disparities, if we're going to close care gaps, if we're going to be able to say we're delivering high quality, equitable care, then we have to move beyond our understanding of the literature and the data, and we actually have to start taking actions. And so the health equity roadmap provides the tools, it provides the resources We have a health equity action library that is an open source. Actually, you can be a member or a non-member of the HA and have access to how-to guides, not case studies that tell a good story, but toolkits. Like, how do I actually stand up? How do I develop a strat plan that has equity embedded in it? What does that look like? And so that's really a big part of the work that the Institute does, is curating those assets and those resources that can help our members achieve the outcomes that they are after. And so I want to share with you just, again, the numerous resources that we have to guide our members on their health equity journey. I want to bring your attention to our upcoming conference in Minneapolis, which for many of our organizations, it's on the heels of George Floyd's murder in Minneapolis, that we really saw this renewed call for social justice and racial justice, and really this doubling down on what is it that health systems and hospitals need to do in partnership with their community stakeholders to move the needle on eliminating health disparities. And so it is very appropriate that we're going to Minneapolis with this theme for our conference, Together on the Quest for Healthy Ecosystems. And so the conference will focus on how to close health equity gaps by, again, really focusing on hospital and community partnerships to develop sustained actions to improve diversity, equity, and inclusion. But you can also see our community health improvement folks have a website that's chock full of information. We developed a societal factors framework that starts at the individual person level. Then you'll see the concentric circles going out to the community level, and then all the way out to the systemic or the societal level. And then last, but certainly not least, we recognize that boards, right, or trustees, or boards of trustees play a pivotal role in holding the hospital and executive leadership inside our hospitals and health systems accountable for really moving the needle in this space. So there are lots of boards that have a quality subcommittee. We've seen a proliferation over the last 3 years of equity-focused committees as well. And I would argue that quality and equity, the leaders, the boards, and inside our hospitals and health systems, the leaders in both of those spaces ought to be engaging in much more collaborative conversations around how to jointly move the work forward. So with that, I want to invite you to visit our websites, and I want to thank you for allowing me to share a bit about why this work is so important and why I'm so passionate about the role of healthcare institutions in engaging with patients, families, community advocates to really change the trajectory for generations of historically marginalized populations in this country. Because I think if we can approach this work with a lift all boats strategy and think about equity not being a zero-sum game, right? That we can create the conditions for all of us to achieve our health goals. And so with that, I want to invite Al back, and I'm happy to answer any questions at this time.
Joy, what a great presentation, truly informative and thought-provoking. And we have a number of questions that have come up. The first one is, if an organization is building a health equity program from the ground up, what is the first step they can take?
So, that's a really good question, Al. The first thing is you've got to secure the commitment from the highest level inside an organization to really moving forward on this equity work. And so whether it's the C-suite, starting with the CEO and all of the executive leaders, and then you can kind of cascade that commitment throughout an organization and embed it at the department level, at the frontline level, where you start to see members of your workforce identifying themselves as equity influencers, right? So at the end of the day, I think you've got to start at the top with the commitment. You shouldn't start from scratch, though. There are leading edge organizations out there that have already done really good work in this space, and we have really good examples of how to begin, how to launch into this work. And so I would say scanning the environment is also another useful exercise to learn from others so that you're not starting from scratch and that you're not feeling overwhelmed as to where to begin. One of the things I will say, when we were designing our equity roadmap, we held town halls, or roundtables might be a better description, with different segments of our membership. So we had a roundtable for our academic medical centers, and we talked to them about, what we were designing. We spoke to our rural members about the equity roadmap. And the one thing across all the conversations that we had, we kept hearing that the healthcare system, most of us, most providers, most hospitals think that they have made major progress in the equity, in the quality space, quality and patient safety. That they've made tremendous strides from a decade ago. And so how can we leverage the infrastructure that exists for that work? How can we leverage that for the quality conversations, right? So if and in fact we can build off of our quality and patient safety work, then maybe it feels like people already have some muscle memory in that space, and we can work from that as a starting point and then apply an equity lens to work that's already underway.
Fantastic, thank you. Here's our next question. How can the Chief Health Equity Officer or leader play a role in leading quality improvement efforts?
So, I think the first thing for any leader who's been charged with this work, and I will tell you that, post George Floyd, we have, I mean, almost every week, it's simmered now, but in the early days, every week, sometimes multiple times per week, I would get an email about a new Chief Health Equity Officer role that had been created, right? Or a Chief Diversity and Inclusion Officer role. And so we saw just a massive response from the field to try to mitigate around some of the concerns that were percolating. What we didn't necessarily see is consistency in how those roles were being designed. And so some folks were reporting up directly through the CEO, some were reporting into HR, some had a budget, some don't. So we've actually this year, in concert with a group of researchers out of Mass General in Boston, we launched Equity Officers National Study, and it's been in the field since October. It closes this month. And what we're hoping to do is collect data from the experiences of these roles that have been newly stood up in many instances, to understand what's the floor. If you're gonna create one of these positions, how do you design them for success? Because no Chief Health Equity Officer should feel like it's his or her job to solely move the needle in this work. That is a recipe for disaster. None of these processes should stand on the shoulders of any one individual. It really has to be that you're taking a workforce, a much broader approach, a much broader lens, applying a much broader lens to this work, so that the work of equity is embedded in all the work that an organization is leading. It's embedded, it shows up in your strat plan, which guides your implementation plan. And so I just think that these roles, these Chief Health Equity Officers, should recognize their limits and should be very vocal around the need to collaborate much more intentionally with other colleagues across the organization, because they're not going to be able to do this by themselves.
Great coaching. Teamwork always wins. The next question we have is, how can organizational leaders help tie different departments like DEI, health equity, community improvement together to collaborate on quality initiatives?
So the word is in the question. Collaboration is key. Again, if you don't have the engagement and the sponsorship from the highest levels of leadership inside the organization, you're already starting at a deficit. So once you've secured that commitment, it then behooves the leaders in each of these spaces to figure out how are we going to collectively design our work processes, our initiatives, so that they're working in tandem with one another. Collaboration is going to be the answer to any effort, whether it's on the quality side, on the equity side, any department you want to put in front of me. I mean, I'm going to say the same thing. You've got to get your leaders together and sit around the table and design programs and initiatives and strategies. And frankly, I would caution us against thinking that we're going to program our way out of this, because so much of this is deeply embedded in policy. Like, we didn't get here overnight. There were policies that were designed. Again, we can think outside of healthcare. If you think about housing and redlining policies that were clearly articulated that Black people would not be allowed to purchase homes in certain zip codes, right? And so the vestiges of these policies are still with us today. So it's going to take an all hands on deck approach to begin to revisit our policies that guide our institutional practices, to unpack and understand whether or not those policies are in fact perpetuating harm. And I would also argue that policies, that's where our sustainability lies, because at the end of the day, leadership will change, right? The administration that we have that's laser focused on equity today will one day not be in place. And so how do you ensure that from administration to administration, from CEO to CEO, from leader to leader, we're not starting over, right? Because that, again, it feeds this narrative that this work, takes forever. Well, maybe if we built off prior gains, we would actually see a little more accelerated effort and a little more progress in all of around all of our agendas. So I think collaboration, a focus on policies that guide practices, that's going to be key to moving, to really making significant and sustained gains in this work.
So here's another question similar to the last two. What steps should leadership take to make sure that health equity is a priority?
Well, I think I mentioned earlier that your strat plan, if equity is not in your strat plan, then it's not being given the right level of focus inside your organization, because we know that what's in your strategic plan is what gets the attention of the board. It's what then gets implemented and executed upon across the organization. So you absolutely need to start with ensuring that equity is part and parcel of the organization's strat plan. I also think the board plays a critical role here, and boards are increasingly asking the question, what is our role in advancing equity? And so there is an oversight function, if you will. There is an accountability function that boards can play, and providing that nudge and asking to see performance data, bring those dashboards forward to board meetings. And so I think it's leadership inside the organization and the leadership that's holding the organization accountable really should be thinking about how do you design processes that then bring forward transparent data that can then be acted upon to drive the improvements that we all say we want to see in our healthcare system. So let's start with a good strat plan that has equity embedded in it.
Okay. Our next question is on information sharing. How can an organization share their learnings from their health, equity, quality improvement efforts with other peer organizations?
So I think that's happening today. Again, I don't think it's a lack of awareness. I think it's that knowing doing gap that I referenced earlier. We know what needs to be done. Do we have the will? Do we have the leadership, transformational leadership, right? For example, at the American Hospital Association, every year we issue an Equity of Care Award. Because again, there are really stellar examples of good work that's happening in pockets across this country. And we want to elevate those lessons and those examples for the benefit of our broader membership. This year, actually, we spent last year updating and revising our Equity of Care Award, because in the past we issued one award winner and a couple honorees. And now we've designed the award so it is in fact more accessible to many more hospitals to be recognized for the work that they're doing. And so we now, starting 2023, we will have 3 awards. We have 3 distinct categories: an emerging, a transforming, and a small or rural category. And so we are very excited to always showcase the good work that we know that's happening, because it inspires others to do even more. And so whether, I think it needs to be well documented what people are doing, and they should be finding different venues to spread the news. Webinars, that's one modality, conferences. But I also think what the field needs more of is how to. So the case studies are great because they tout the outcomes that an organization has achieved. But what folks really need to move the needle in this space is, well, how did you do that? How did you go from a board that lacked diversity to a board that now has, 20% gender diversity and another 20% racial and ethnic diversity, and the age, they're not all 65 plus older folks. Like, how do you do that? And how do you make that happen? In what period of time? How long is it going to take? What are some considerations? And so I think it's important for us to democratize the information, make it accessible, find different venues to push it out, celebrate and recognize those who are doing good work through awards like yours, and continue to just, again, spread and scale, spread our messages. I think that's part of the issue we find, is that, there are these pockets where the work is happening, but it's not necessarily clear to others how to engage. How do they dip their toe in the water? And that's why we're really excited about our equity roadmap, because it doesn't matter where an organization is, where a group of leaders are in this space, in this work. We can meet you wherever you are and give you the resources and the tools, and frankly, the evidence to help you understand why this work matters, why it makes lives better, and why it is important to lean into it fully.
I just want to build on that for a second too, from a Baldrige perspective, just to remind everybody out there that the criteria has DI embedded throughout, from leadership and strategy all the way through processes and outcome and results. And much of that is how-to processes, how-to questions that are answered by award-winning organizations in their self-assessment. And those self-assessments are all available for free on the NIST website. So if you want to see a world-class Baldrige winning organization's processes around these subjects, all you have to do is go and download their self-assessment, and you can get a great deal of information there, as Joy was talking about, on just how to build processes around these issues.
That's true for our Equity of Care Awards as well. If folks go to ifdhe.aha.org, which is the Institute's website, it houses just a vast array of resources. But one of the tabs is dedicated to our former Equity of Care Award winners. And so you can start to read and learn and begin to understand, well, again, how do they move from point X to point Y? How do they do that?
A lot of great tools out there. Our next question, Joy, is if we're no longer using determinants as vocabulary, what's the new vocabulary?
Sure. So drivers, that's a really it's growing in its usage. Social drivers of health. The other one that we embrace at the AHA is the societal factors that impact health, because again, the nomenclature matters, right? The way you speak things into existence, it does matter. And so when we talk about determinants, it almost lets some folks off the hook to say, well, that's destined, that is determined, that is just how it's going to be. Versus we actually have an opportunity here to impact that particular outcome. And so if we apply the right dosage, if we apply the right level of intervention to this scenario in front of us, we can make an impact. We can create better health. And so we're very, very intentional around, we have an internal at the AHA, we have a DEI terminology guide that we've developed with input from folks across the association. And it's not, it's our own document. We're not prescribing it to others, but we just know how important words are. And that when you start talking about something being a determinant, it makes it as if it is hardwired and it is not modifiable. And we know from the evidence that we actually can improve health if we, again, apply the right interventions. So social drivers of health and the societal factors that impact health are the two I would recommend.
Joy, that's all the time we have. We've got a number of questions still out there, and I just want to remind everybody that we will get back to you with email responses to your questions if we weren't able to address them here. And all of the information presented today, a copy of the video as well as the slides, will be available on the Institute's website next week. I also want to remind everybody, we have a number of courses in the Institute website around this subject. Leading DEI efforts, a diversity, equity, and inclusion healthcare yellow belt certification course, and a number of other courses that are showcased on our website. So please take a look at baldrigeinstitute.org and the courses that may appeal to you, which can be done all online, self-paced. Lastly, I just want to thank again, Joy, what an outstanding presentation that you gave us here today. And thanks everybody, especially to our sponsors and members of the Mac Baldrige Society who serve as trustees for the Institute for Performance Excellence. It's their generous support that makes presentations like today's possible. Thanks again for tuning in, everybody. Please be safe and have a great day.